So we'll just go ahead and yeah. Mike, can you switch on the mic?
I wanted to share an interesting case where the patient was presumed to have a CNVM, but the etiology was not mentioned earlier. This patient came for an opinion himself. Patient had poor vision in one eye for many years, and the left eye he just had a recent drop in vision, recent about 4 to 6 months, and he had gone to another eye center and he had got 2 intravitreal injections. At that time it was he had received Lucentis injection in the left eye and there was no improvement, so the patient came to us. So there's you can see a scar here and you can see a yellowish lesion on this side in the left eye, and the OCT at this point of time, for at least for general ophthalmologists, for us retina people, we are used to name changes or new names coming up every few months and trying to understand what it is. But if for general ophthalmologists, you don't have to worry as long as your basics are correct. If you see something subretinal high reflective, does not necessarily mean that it's a CNVM. In a CNVM, the choroid, the RPE has to be disrupted even if it comes into the subretinal space that is above the RPE. So in this patient, you have a high reflective subretinal lesion, you have some fluid, but overall the RPE here is quite intact, maybe some double layer sign which is forming over here. But since this patient had also not improved after 2 injections, we definitely, I mean demographically this patient, I would say that I had a very high suspicion of CSR. This patient was from West Bengal. But then the right eye obviously was not very typical of that, all the pigmented scar, but you can have in some cases. We did an FA, you see that ink blot leak over here, very nice. And then you see the choroidal vascular hyperpermeability, which was shown in the earlier cases also. Whenever you see a diffuse choroidal vascular hyperpermeability in patches, that is highly suggestive of CSR, and the CSR leak in fact is shown very well on ICG also. We are all used to learning during our PG that FA is good for retinal diseases and the leak is less in ICG, but in CSR, a typical CSR leak, whether it's ink blot or smokestack, is very well seen on ICG also, as in this one here. We went ahead with laser, focal laser, because quite close to the FAZ using Navilas laser. And this is the photograph comparing the pre and post laser. So patient came to us with already 2 anti-VEGF injections. This is how it was. And after 1 laser and 2 months, no further injections, this fibrin has disappeared. There's no fluid now. So this was a case of CSR with no CNVM. Although if this was a time when we did not have OCTA, but if we had done an OCTA and looked at this double layer sign, maybe something may have shown up. We may have been worried about an CNVM and may have injected. But yes, the main pathology was CSR and we did laser, it disappeared. So this is just to compare the FA and ICG of a CSR patient. You see in the right eye also, while the left eye is showing a nice ink blot leak, the leak is very prominent on ICG too. So ICG leaks very well in CSR. But the right eye, which was normal, also is showing choroidal vascular hyperpermeability patches, which is extremely important to know in CSR. And if you do autofluorescence, you'll find changes in that too. The advantage of FA and ICG versus OCTA is that in OCTA, because it's dye-less, it cannot pick up any leak. It can pick up flow areas of blood vessel, new vessel formation, but any dye leakage because of either outer blood retinal barrier leakage or inner blood retinal barrier leakage, you need FA or CSR. So these are some of the points I just wanted to touch on. You cannot forget or remove FA and ICG from our practice at this point of time. Thank you very much.